Okay, so the first thing I have to say is that I'm here on behalf of two people, myself and Professor Rebecca Jester. Rebecca sends her apologies. Unfortunately, she had something going on in her family this week that meant she couldn't leave the UK. So I'm pretending to be Rebecca and myself. And if anybody knows Rebecca, they know we're really good friends, but actually we're quite different. So I hope I'm going to be able to do her justice as well as myself, and yourselves, of course. So what we were asked to talk about was the development of nurse-led services, in orthopaedic nursing in particular. And we had quite long conversations about where we wanted to take this. And you're going to find in the presentation, I'm going to talk about outpatient stroke ambulatory care services mainly, because those who work in ambulatory care stroke outpatient services have been the ones that have led the way in orthopaedic nursing in terms of nurse-led services. Because acknowledge everything that I've heard here today, I've sat at the back listening quite carefully, has been about what an important part of the orthopaedic patient's journey nurses are, and how in the future we're going to be even more central. And if I just say to you, the more I think about artificial intelligence, the only members of the healthcare team that aren't replaceable by AI aren't the doctors. Because there's an argument in the literature that a lot of what doctors do can be replaced by algorithms and artificial intelligence. It doesn't work like that in nursing. And I'm sure that's true of physiotherapy and a few other things as well. But we're absolutely central. And that's perhaps one of the main messages that Rebecca and I wanted to get across. So I'm going to come a bit further forward because my glasses will only let me see this if I stand here. So what we really want to do today is just outline the development of nurse-led services. And I'm going to make quite a UK focus to that because that's what Rebecca and I know about, but try and transmit that out to the rest of the world. And the big thing that I really want to talk about is what's the benefit of having nurse-led services, just so that you're really sure that when you're developing or running or redeveloping or reviewing your nurse-led services, that you are really sure that you are doing absolutely the right things for your patients, because the benefits are out there for all of us to see. So we'll explore a little bit of the evidence, and I want to talk a little bit about training and education, because obviously that's one of my passions. And that was what Rebecca and I agreed that we were going to talk about, and then I added another slide. So I just wanted to add this little extra. So I want to congratulate you. Because, particularly now, 6 months ago, I decided to retire. So I've actually been supposedly a woman of leisure for the last 6 months, but it hasn't really worked out like that. So the official word is that I'm living on my investments and I'm no longer in full-time paid employment. So that means I'm working really hard, but not getting paid for it. But I'm lucky to be able to do that, because what my career has meant for me is that because I wrote some papers that somebody read and worked on some books with a few people and had a big mouth and said a lot of things, I've been able to travel the world talking to orthopaedic nurses everywhere for the last 25 years. And what I know from that is that you're amazing, truly amazing. And I know it's tough out there, and it's getting even tougher by the week. You know, when I look back to my first day as a student nurse in 1979, boy, did I think that was tough. But what you're dealing with every day now is so much tougher than anything that I saw at the beginning of the 1980s. So I want to congratulate you as my friends on the amazing progress that you've made in my nearly 40-year career, because it has been incredible. But I want to do a little bit of inspiring as well, and I want you to think about where you want to take this in the future. With us old uns who've got all that experience of having been through all of this stuff since, for most of us, the 1980s, those that have been around quite a while, but inspire you to think about a future that can be whatever you want to make it. Don't listen to the managers. Sorry, Mayanna. Or anybody else who happens to be here. Don't listen to them. You think about what it is that you want to do, and you take it where you want to go. So we'll do a little bit of that. And I also want to continue encourage you to continue to collaborate internationally. Because as my colleagues were talking about this morning with the Fragility Fracture Nursing Project, I have so learnt the benefit of collaboration these last few years. That project is truly amazing, but it's only happened because we went out there and developed a network. And working together is something that we're getting better and better at every week, helped by the internet, helped by enthusiastic people that really believe in it. But when it comes to nurse-led services in orthopaedics, it's you that leads the way. Beyond anybody else in the team, you're working in a team, but you're the ones that make the real difference. So that picture there is a picture of my favourite mountain. It's actually called Monte Viso. The French call it something else because it sits on the border between northwest Italy and southeastern France. But you can see it from the top of the hill where my little shack in Italy is, in northwest Italy. And I haven't been to the top of it. And one of the reasons I retired is because I have back pain, and I've had it since about the mid-1980s. And my goal is to get to the top of the mountain. And I think real, amazing nurse-led services are your Monte Viso. And those flowers up there were amazing. So I haven't quite got there yet, but I'm going to, and you're going to get there too. But probably I'm going to be needing your services more than anything in a few years' time. So first of all, the evolution of nurse-led services in orthopaedics, and it's varied globally. And one of the problems with coming from the UK is we think we do everything first and best. And I think every country thinks that sometimes. What I've noticed about Denmark, and I'm sure they won't mind me saying this, they're very coy. They don't like talking about how brilliant they are at things. But actually, there's some stuff that's been going on here and lots of other places really quietly for lots of years. But because you've got a small population and we've got 65 million, we just make more of a song and dance about it. That's what it really is. So, but I can talk about the UK. I know a lot more about that than I do anywhere else. So in the UK, nurse-led services started with pre-operative assessment clinics. And the reason that happened was because we were concerned about the number of patients that are arriving at hospital like days before the surgery was going to happen who weren't ready for the surgery. So the fix for that was perceived to be having the patient seen by a nurse beforehand, and we've worked over the years at when's the appropriate time for that and what we should do with them when they do that. And we also developed patient education services at the same time. So we called them things like joint schools or education sessions. And that really started at the beginning of the 1990s. So 1990s, 2000s, and now this decade, that's 30 years of continually developing new approaches to these services. And nurse-led services internationally have really mirrored the development of things like advanced nurse practice roles and specialist nurse roles. And we could spend all day talking about those because the definition of those kind of things is very different around about the world. But right there in the middle of all of that development has been orthopaedic nursing, and at the forefront. But what's interesting when you think about nurse-led services is actually it has a much longer history than you think it is. Can anybody tell me who the lady with the crutches on the right-hand side is? Have all my UK colleagues gone home? Thank you very much. Who was that? Wave your hand at me so I can see it was. Thank you. So, Dame Agnes Hunt was the first orthopaedic nurse in the UK. And she was a little bit of a later-day Florence Nightingale character in that she came from a wealthy British family up in the sort of like mid-west of England on the border of North Wales. And she trained to be a nurse despite the fact that she'd had osteomyelitis as a child and had significant mobility issues. And she wore both calipers on both legs and walked with crutches, but still managed to get trained up as a nurse. And in the early part of the 20th century, she set up the first orthopaedic hospital, which was actually called the Bath Church Home for Crippled Children. And we used language like that in those days. We wouldn't dream of calling it that now, a century later. But what's important about that is that the idea of crippled children was usually children who had osteomyelitis, poliomyelitis, tuberculosis of bone, which was very, very prevalent in those days and has now thankfully been largely eradicated, who had significant mobility problems as a result of their long-standing orthopaedic infections. And she recognised that by taking care of them more effectively, they may well improve in their health. So she took over a house called that she called the Bass Church Home for Crippled Children, and initially started with a few children and eventually ended up being 20-something. Now, what's important about that was that the treatment was fresh air and good food. So the picture down here that you see of a few children in what looks like some kind of strange box was actually an open shelter. And they were out there in the winter, in bed, covered up with blankets, breathing fresh country air, because it was in Shropshire, where it isn't very built up in the UK, and it's a very beautiful part of England. Come rain, winter, anything, I suppose that's feasible in the UK. It may not have been such a good idea in Denmark, and certainly not Iceland, but in that part of the UK, we don't have very, very, very low temperatures like you do in Scandinavia. Now, eventually, the man on the left came along, and he's a chap called Sir Robert Jones. So the eventual hospital became the Robert Jones and Agnes Hunt Orthopaedic Hospital, and it still exists today, and that's where I did my orthopaedic nursing training. But that took some time to happen. And what had happened to the children under Agnes Hunt and her nurses' care before any doctor got involved at all was that their health improved because they had good nursing care, fresh air, sunlight when it was available, and that was the thing that made the difference. And when Robert Jones came along, he said to her quite a few times, I don't need to perform surgery on this child because they're doing perfectly well under your care. Don't we wish it had stayed that way? But that's not the reality of the world, is it? But I just wanted to tell you that nurse-led care is actually well over 100 years old. It's just that we got a bit muddled up about what we were doing along the way. Okay, so there we go. Oh, sorry. Oh! What did I do? Thank you. We're in the right place now. So, these days, we have to think very carefully about how the drivers for nurse-led services have changed. And these are what I think they are, what Rebecca and I think they are at the moment. So, increasing chronic and age-related health conditions, along with an ageing population in every country in the world, some greater than others, and the increasing cost and demand for health services means that in most countries, even wealthy ones like Denmark and less wealthy ones like the UK since the Brexit problem, but we won't go into that, has meant that we've had to look really, really closely at the resourcing of our health services because we can't afford to go on like that. And that's unfortunate. And the other thing that's unfortunate is when it comes to reducing resources, because nurses are the biggest cost, it's often us that's the one that gets the angst and anxiety that goes with that. But with that's come an increasing amount of ambulatory care, or what we call outpatient care in the UK. Telehealth services have been developing incredibly over the last 10 years. And the other thing that we've got is much higher levels of nursing education and skill. So we have a workforce of nurses who are prepared to be able to take on additional and extended roles. But most importantly, and I really shouldn't have put this at the bottom, nurses are very, very, very good at patient-centred holistic care. And if you want the whole patient to be cared for, then you make a nurse lead your service, because they're the ones that will make a difference to the whole picture. And I had a conversation with a Danish surgeon that went just down this road the other day about, you know, he does the surgery and he does an absolutely amazing job of it, but when it comes to the rest of the story, that's down to us and we can make or break the patient's journey afterwards. So what that's telling us is that nurses are central to absolutely everything that's changing in healthcare, and we're up there making it happen, and we have been for a long time. So some examples of nurse-led services that I know about in the UK. I've no doubt you'll be able to think of quite a few that are different to this. So one of the things that's been really big in the UK, and I know it is everywhere else as well, is follow-up review of following elective procedures such as total hip and total knee replacement. And these days, that follow-up service is sometimes face-to-face, but more often than not, it's becoming what we call virtual, either by telephone or some kind of a technological innovation. We've also got lots of opportunities for nurse-led services in chronic wound services, and that area is really quite interesting. So when we talk about chronic wound services, we're often talking about leg ulcers and other kinds of wounds related to vascular problems. And part of the reason the nurses have taken that over is because nobody else is interested. And, you know, there's something about nurses. I teach wound care to student nurses quite a lot, and they get so excited about it, whether it's a leg ulcer or anything else from that point of view. And our medical colleagues don't. So we've started to take that over, and we're making a real difference from that point of view. Back pain services. There have been back pain services in the UK for some time now where back pain triage, patients who have back pain, who are referred in from community services and GPs into the hospital setting, potentially for surgery, are seen initially by a very senior advanced nurse practitioner and who makes decisions about what's the right pathway for the patient to be in. We've had, we have trauma nurse coordinators, advanced nurse practitioners. Fracture clinic follow-up is increasingly being undertaken by nurses. Fracture liaison services, and there are some instances of surgical care practitioners. So one big thing there was a few years in the UK where very senior and experienced nurses were trained up to perform very simple and complex procedures like carpal tunnel surgery. So it's across the board in orthopaedics that that's happened. But like I said, I want to focus a little bit on ambulatory care in a minute. But the real benefits to all of that are what? Well, like I said, the most important thing is that nurses are able to take a holistic approach to patient care in a way that no other health professional does, because we're the ones that are the overarching professional who coordinates the care and makes sure everything happens for that patient. So we know far more about them than anybody else does. And that's not in less detail, it's in a great deal of detail. I don't like the fact that what that means is that it enables our medical colleagues to go off and do things that we can't do, because I don't think that that's actually an appropriate reason for nurses to be taking on roles that were previously performed by doctors. And that's just something in my heart about that we shouldn't demean nurses in that way. But in fact, that is what's happened, is that it's enabled medical colleagues to be freed up to be able to deal with more complex issues. And we could be here missing our dinner by debating that this afternoon, so we won't. Some literature argues that it's more cost-effective to have a nurse undertake these roles because they cost less than medical staff. Actually, that's quite debatable, and the literature's uncertain about that as to whether it's actually cheaper to have a nurse undertaking those roles than it is medics, because often those roles are undertaken by quite senior nurses who are quite a long way up the pay scale, and they cost more than, for example, a more junior, recently qualified doctor. And the other worry about all of that is that the more you take nurses into those roles, the more they aren't able to do the other things that nurses need to be doing. But the good thing for us is that there's an opportunity here for nurses to further develop their skills, further develop their competencies, and further develop their scope of practice. And what that's enabling us to do is find roles for senior, experienced astoundingly expert nurses to keep them in clinical practice rather than them going off into management or other kinds of areas or moving around. So what it does is provides nurses with that extension of their scope of practice that really enthuses them about what they're doing, enables them to move forward. So there are significant benefits, and it's not just about saving money. Next question, I suppose, is are they effective? Absolutely yes. Absolutely no doubt about that whatsoever. So 2 examples here. One study showed that nurse practitioner consultations are comparable to those of medical doctors within a secondary care environment, so in the hospital setting, in terms of getting the diagnosis correct and undertaking therapeutic treatments. So we know from several studies, and I'll give you some illustrations of that in a minute, that we definitely know that in this situation, a nurse is as good as a doctor, and sometimes better. So here's an example. This is from a paper from back in 2005. So this has been going on quite some time now. And my children's nurse colleagues will be quite pleased that I've mentioned this. So way back then, there was a nurse-led paediatric clinic for hip dysplasia. And it was reported that there were very high levels of acceptance of the service, and 100% of parents were highly satisfied or satisfied, and that they particularly appreciated the improved waiting times to see someone about their child who they had been told may have hip dysplasia. And only 3 weeks ago, I was in Dublin, Ireland, listening to a presentation about some nurse-led services there where they're now running virtual hip dysplasia clinics because parents have to travel quite long distances in rural Ireland to get to the hospital. And what that means is that they talk to someone on the phone who allays their fears, and that happens much more quickly than it would be for them to be brought into the hospital. So we know there's plenty of evidence out there, specifically in orthopaedics and in all sorts of areas as well, that tells us that we are being very effective in this area. So just to illustrate that, a few case studies, particularly from outpatients and ambulatory care. So arthroplasty follow-up. Here, what I tried to do was look for a bit of literature that I could just give you some examples of. So this is from the British Journal of Healthcare Management, published in 2018. And what this is about nurse-led follow-up, replacing a consultant orthopaedic clinic. So what the team there have done is undertaken an evaluation of a nurse-led domiciliary follow-up clinic, and what they found was that the pathway utilisation, safety and patient satisfaction from a postal survey showed that during the study period, the pathway utilisations, there were 30% of patients who'd undergone total hip replacement and 27% for total knee arthroplasty were deemed safe, with only a 10% re-referral to consultant clinic rate and no reported adverse outcomes, and patients reported high levels of satisfaction. So those are the kind of things that we're interested in knowing whether this nurse-led follow-up was being effective. Second one that I want to talk about is fracture liaison. And now, Rebecca's background is elective orthopaedics and mine is trauma. So you probably find that I'll give you a bit more information about this. So going back to the fragility fracture presentation this morning and just honing in a little on the stuff to do with secondary fracture prevention. This is from the National Osteoporosis Society, which is actually now the Royal Osteoporosis Society in the UK. The point here is that we know that sustaining a fragility fracture of any kind is a signal that another more serious fracture is likely to occur sometime in the quite near future. And that if we can prevent those fractures, that must be something that we need to do, because that way we're going to end up with less of them needing hospital care in the future, because it's a sign that someone may have osteoporosis. And the big thing about that is it's a very multidisciplinary problem, hence the existence of the Fragility Fracture Network. And what everybody's very clear about is that there's no one professional group that should take any particular responsibility. We should all work as part of a team. But the problem at the moment is, in most places, people with fragility fractures are not advised of their high potential for getting another fracture, and they never report this condition in surveys because they don't know they have it. So we don't actually know, unless any of you have had a DEXA scan, how many people sitting here actually have osteoporosis. And I suspect it's quite a significant number already because of all of the risk factors that go with osteoporosis in women. The other problem that we have is that coding in health records is very poor, so we don't necessarily know who they all are. And we have a lack of international codes. So the big issue is, despite the ease with which the first fragility fracture, the wrist fracture or whatever, can be identified because it's there on an X-ray, you can see it, and the effective drugs that can reduce the risk of the refracture, there's still a significant care gap, and people aren't being put into a system whereby the connection can be made between that first fracture and their need for treatment for fragile bone osteoporosis and therefore prevent the next fracture. So the majority of patients all over the world, including in the UK, with fragility fracture are not tested or treated for the underlying cause, osteoporosis, and it's estimated that only 20% of fractures are treated appropriately, those minor fractures that come in first. So that is a really significant problem, and we just don't talk about it. So the recommended global approach to that is fracture prevention services, and we call them fracture liaison services. So the aim of those is to have a process in place that makes sure that every person who sustains a fragility fracture in any part of the skeleton has specifically organised care to manage that. They understand the need to improve their bone health and why that's the case, that their bone health is investigated. They have local access to the required services to help them do that, and that the health teams in both secondary and primary care collaborate to ensure that that happens and that they're followed up regularly. Sounds really simple, doesn't it? But, you know, there's only quite a small percentage of hospitals in the UK that are currently providing that service. And the talk all throughout the literature about fracture liaison services is that that should be a team approach. But in nearly all of the services where this is actually taking place, the person who is leading that fracture liaison service is, guess who? The nurse. A nurse, an experienced, passionate nurse who knows everything there is to know about leading this kind of service and brings all the other members of the multidisciplinary team together. Sometimes it's a physiotherapist and occasionally it's another member of the team, but it's usually a senior nurse. And they act as the link, bringing people into the clinic, seeing patients, but making sure that patients are then referred to the right person to make sure that they get the right prevention treatment put in place. And they do things like coordinate steering groups to make sure that's happening. They maintain all the records, and they lead in development, the implementation and evaluation of fracture liaison services. And they also support and encourage other team members with their knowledge and skills development. So it's a pretty big role, and that's maybe part of the problem in terms of its implementation. So what about the success of that? What do we know about whether these fracture liaison services make a difference? Because, you know, you can hear how complicated they are, and they might immediately be perceived as being quite expensive to run at a time when we know that hospitals and other health services are under pressure. So here we go. This is a paper which was a review of the literature fairly recently, 2017 in Injury Journal. And here's the important bit. Experience has taught us that by delegating responsibility for the holistic care of the patient to a trained and adequately resourced professional team, i.e. fracture prevention practitioner, with clear standards against which benchmarking occurs, is the optimal model of delivery, to the point where the statistical models are now demonstrating how many fractures have been prevented as a result of these services, and savings in money into the tune of hundreds and thousands of pounds. So it's actually very well proven that that kind of service, if run properly, and you can't do it as a just, oh, we'll have a bit of a go and we'll say that nurse is going to set up a fracture liaison service and they go on and do it. It has to be a whole organisational approach to it with everybody in the team on board and real championship. And we know that that ultimately is what's going to make a difference to the fragility fracture problem. But at the moment, we're not seeing a reduction at the other end because we're not doing enough of it. And that's largely led by nurses as part of a multidisciplinary team. And then the third one I just wanted to mention is hip dysplasia again, because I mentioned to you that there's a lot going on in children's nursing, both from that and the other common conditions that affect children. And nurses are leading the way in that, things like hip dysplasia and stuff like that. And like I said, there are some virtual services now starting to pop up that are making a real difference, because there is nothing worse than being a parent of a small child and having to drive for 40 minutes to a hospital to see a surgeon for 5 minutes who tells you that your child needs to be sent somewhere else for its treatment. So that's not good quality practice, and nurses are making a difference with that. So if we look at nurse-led services generally. So this is a systematic review that looked at 25 studies of different kinds of nurse-led services. So those studies added together, this is from 2018, they considered in total 180,308 participants. Now, these are the interesting bits. Of the 16 studies that measured and reported health-related quality of life outcomes, the majority of studies reported equivocal outcomes. So what that means is we weren't very sure about whether the outcomes were good or not so good. And they were largely comparing nurse-led services to medically-led services. But 3 studies on top of that demonstrated superior outcomes from a nurse-led service, and 1 demonstrating inferior outcomes. So, and a lot of this is not about that anything's not good in these services. It's usually about the quality of the research not being very good, and we're just not doing enough of it. But here's what they say following this review. Nurse-led care demonstrated either equivalent or better outcomes for a number of outcomes. So there were some particular outcomes that nurses seemed to be able to make the best difference to. So symptom burden, so patients were saying that as a result of the nurse-led service, their symptoms were better. Self-management and behavioural outcomes, so nurses were making a difference to how well patients could manage themselves and were changing their behaviour. Disease-specific indicators, so there might be a pain indicator for a particular disease. For example, nurses were particularly good at helping patients to change things in their lifestyle, for example, that would mean that their indicators for that particular condition would be better, as well as satisfaction, perception of quality of life, and health service use. So across the board, nurse-led services are making quite a difference. So I'm aware that you probably want to go and get your glad rags on, as we say in the UK, ready for your dinner this evening, wherever you're going. So Rebecca has set up nurse-led services herself. And these are the things that she wanted us to tell you about top tips for setting up nurse-led services. Because what I'm hoping you're doing is thinking, gosh, aren't we good? And couldn't we be doing some really amazing things in the future as things develop? And some of you might even have a really bright light bulb moment idea that's come to you today or tomorrow or next week where you're thinking, you know, a nurse-led service would really, really make a difference to that. So if you want to do that, or you want to develop the service that you've already got, or you want to make a difference to something, this is the advice from Rebecca and from the literature about what you should be doing. So the first thing you have to do is you have to have a clear business plan. Nurses, business plans? Yeah, sometimes, and sometimes not. But there are people in your organisation who know how to write business plans. And not only does that make a difference in terms of you convincing others what you need to do, especially if you want to do something like getting interest in a fracture liaison service, which I would actively encourage any of you working in that area to be thinking about, but you can't do it on your own. So you need to get other people on board, and in order to do that, you need a really sound business plan, and that takes quite a bit of work. So you need a business plan expert, or at least somebody who's got quite a bit of experience to it to help you. And people who know about business plans are a bit geeky, and they love helping other people to develop them. So never hesitate to ask. And what that will involve is good leadership, so you know who's leading this forward, and it's somebody who's got the energy and skills to do that, but you need a proposal outlining the rationale for the service, including if it's replacing an existing service, or it's an adjunct to, or it's a completely new provision, who the stakeholders are and how you're going to involve them. And big in healthcare these days is involving patients, users, carers, community members, voluntary organisations. So they're really quite an important part of it. And the other third thing that's absolutely central is thinking about the education needs of the people that are going to be involved in delivering the service. In terms of planning, so if you get into the stage where you've actually done the job of convincing everybody that you're going to go and start making some plans for this service, the biggest job is developing protocols, the actual nitty-gritty of how they're going to happen. So who's going to do things like request x-rays, who's going to look at them, how are they going to look at them, how are they going to be trained to do so, who's going to report on them, who's going to check what they've done. Thinking about what does professional indemnity and vicarious liability involve? Have you got adequate resources in place? What do you need in terms of equipment? Things like clinic slots, consulting rooms, and very importantly, support staff and administration. Too many times have I heard about nurse-led services that have failed because a nurse or two nurses were left to run the service completely on their own without any administrative support. And nurses aren't administrators. You know, there's lots of paperwork that somebody much cheaper than them can do, but more often than not, we don't follow through the thinking about how those nurses are going to be supported in dealing with the lots of bits of paper that are going to come in through. And then you have to agree an evaluation strategy. And when you do that, then you'll be sorted. I just wanted to mention again briefly the whole virtual clinic thing, because this is becoming really important in orthopaedics. So when I was looking for some research for this is a paper from this year from Bone and Joint. Here we go. So this was about clinical cost effectiveness of a virtual fracture clinic service that was run by nurses and orthopaedic surgeons. The virtual fracture clinic led to fewer referrals to face-to-face fracture clinic, improved waiting times from referral to first orthopaedic reviewing clinic, ensuring more timely management decisions and fewer unnecessary referrals and less non-attendees, meaning more patients were saved the time and expense of coming to the hospital. And I know that's something that a lot of people are working on. So education is the final thing that I really wanted to mention before I finish about, you know, this is now something that most of us, as you know, most of you that are developing your skills or have developed skills and could develop more, need to be thinking about in terms of what can I as an individual, whether I'm developing a nurse-led service or not, do to develop my skills in this area. And one of the problems that we've got is that it's not always possible for the education to come to you. You have to go out and make it happen for you. So how can you develop your skills in assessment and examination? How could you do that without necessarily going on a university course? What about developing your skills in understanding how investigations work and how to interpret them? What about diagnosis? It's no longer the case that we say that doctors make diagnoses and nurses don't, because that's not true of the nursing profession anymore. What about learning about treatment? What about prescribing? What's the situation about nurse prescribing either a limited or a broader range of medication in your country? And what about evaluating the outcomes and the measurement? And thinking about things like professional conduct, and law. And I put a little question for myself there to say to you, there's a lot of debate in the nursing literature about people who are going to be advanced nurse practitioners or run nurse-led clinics or anything like that, that they need to be educated to master's degree level. And there's a lot of literature about that, but I'm not completely convinced. Actually, what it matters is what you know, how you interpret that into what you do. So, a couple of important messages then. You are such a large and powerful workforce. You really are. I'm not sure you always believe that. And if you work together, locally, regionally, nationally, globally, you can revolutionise the way that healthcare is delivered. It takes a bit of energy, and I'm not sure you've always got it every day, but there's plenty of it going on in this room at the moment. And secondly, you just need to believe that you're unrivaled in your skills and knowledge, because you are. But now, when I was thinking about this presentation, I was thinking, what's been my approach to life for the last 40 years? And I think it's be brave, even if you're not, just pretend to be brave. Maybe the Australians will sort of like get it. We don't have that many sharks in this part of the world, do we really? And if I can't say anything else to you, just soar, be bold. Be brave and believe that nursing has a really, really bright future in terms of delivering amazing services to patients. You've just got to believe that you can make that happen, and anything you want to happen can. Just be a bit brave and don't tell anybody when you're frightened. Thank you so much.